Hi there, thanks for watching. My name's Sarah Jane. I am a musculoskeletal podiatrist and I am the clinical director of the Rehab Hub in Glasgow. I'm making this video and a series of videos because 6 days ago I ruptured my Achilles tendon. This is an injury I know really well, and I'm hoping that this, I suppose, my own case study that I'm going to document all the way through this will help maybe you if this is an injury that you've done, or maybe you're a clinician and you can learn off this experience and come on this journey with me and learn so that you can best help your patients or other people who are interested in this injury. Little bit of history I think is important. It's very important with this injury. So I myself in my job, I work in a rehab setting. I know this injury day in, day out. And my career is kind of all the way has kind of led me to this. So in my early 20s, I used to be a semi-professional runner. My events were 800 and 1500 meters. So in my head, running is something I've always done well. It's always been something that I've done. In my early kind of late teens and 20s, I then went into personal training. So my kind of first undergrad was sports and exercise science, then went on and did personal training. And I used to take all my clients running. That was my thing. I'm now in my 40s. I'm well into my 40s. I'm 44 and I'll be 45 in a few months. So that was a while ago now. And through my career, as I have got injuries, because I have had a lot of injuries, actually, that was one of the reasons that I stopped my kind of professional career as a runner. Was through injuries, and that led me into then helping other people. And from there, I became a personal trainer. From there, I went on and did sports therapy. I became a Pilates teacher. Still do that now. That's a big rehabilitation tool that I use. And then went on and did sports therapy, and then podiatry, and I specialise in MSK Podiatry. And currently a PhD student at Glasgow Caledonian University. Primary focus on rheumatoid patients with biomechanics, big major, and diagnostic ultrasound there. So I'm very well used to these injuries and working with patients with them, and here I am with them. Little bit of history of this injury and how this is kind of built up on me. So I did it when I was running. Now I shouldn't have been running, even though in my head, running's my thing, is my identity all through. If you'd ask anybody I went to school with, Sarah Jane, they'd be like, "Oh yeah, the runner," because that was who I was, what I did. That was the one thing I was really, really good at, really good at. Anyway, so in my head, that's who you are. I ran when I shouldn't have. It was stupid, and I'll explain why. So hopefully you don't. Hopefully you're watching this and you've maybe not ruptured. You're just injured. Maybe you've just hurt something and you're worried about it and you don't go on and rupture. Or maybe you've ruptured yours like mine, and you can maybe learn from this. But essentially, with all my running and everything that I've did over the years and all the injuries that I've got, I had to have a full hip replacement. It'll be 2 years this August. It was my left hip, so I had a total hip replacement, which I am very young for. But again, my personality is I'm crazy stubborn. I think a lot of sports people like this, crazy stubborn. I will push through. Pain doesn't ever stop me. I have a insane work ethic. I push myself. I've always been like that. So, and that in some ways can be an amazing quality to have, but in terms of pushing my body, and especially with musculoskeletal injuries, it's not been a good thing. So I subsequently had a hip replacement in 2021, and that was on the left side. Now, my right Achilles, if we imagine how I was walking and had to, I was offloading that left side, my right side was doing a lot more. And actually, through my rehab of the left hip, I kind of felt my right Achilles was a bit stiff and nothing that ever needed like shockwave therapy or anything that I would give other patients. It was never that bad. Slight kind of plantar fasciopathy. We know that the tendon does continue down under into the foot as well, that kind of fascia tissue. So I would get a little bit of grumbling, but nothing major. And I was always good at stretching it out. I was on the reformer. I'd always do my mobility work, stretch work, eccentric loading. I was doing all of that. And so it was nothing that gave me any concern. It was nothing really that had any impact at all. So it wasn't that bad. But there was that underlying chronic tendinopathy. So there was no active inflammation in that tendon. It was just this grumbly, annoyed tendon. So we call that a tendinopathy. So on Thursday last week, now bearing in mind I'd had a hip replacement not even 2 years ago. I haven't been doing any running. Really, the last time I did any kind of big run was 2012. So we're talking 11 years ago. Um, and on Thursday last week, I stupidly decided through my pig-headedness and competitive head that I would run in the parents' end of term at all the nursery mums and dads in a race, 100-meter sprint. Now I wasn't dressed for the occasion. I was actually wearing a dress and a pair of kind of almost flip flops, or better than not quite flip flops, but essentially I didn't have trainers on. So when I was running barefoot as well. It is to say I am an idiot. I would, if this was one of my patients, I'd be like, "What are you doing? Are you crazy?" The ground reaction force from that, you've not done any training. How ridiculous to think. Anyway, off I went, 50 meters down, and I felt it. Now I would say about that kind of 35 meters, I felt something before it ruptured. I felt a twinge that I should have stopped, but I didn't because I am insane. I think there's something in my DNA that I just push through it. It's just that thing where pain doesn't stop you, you just keep going. Um, and I just kept going. And it's like everybody explains, you hear it. I heard it and I felt it. It does feel like somebody has booted you in the heel. And I felt it pop. I heard it pop. And I immediately fell forward. So I actually fell forwards. Now, as that kind of process, it was probably like a split second, but in that moment, I knew what I'd done. I knew what I had done. But then there was this little bit of doubt. I was thinking, oh, actually, maybe that lady behind me just like went up on my heel when I was running. And I said, did you? And then like as soon as I'd said it, I was like, no, she didn't. Your Achilles has ruptured, SJ. And it had. So I kind of hobbled off the area that I was on and immediately sat down. Now, this is listening to this, so especially those clinicians or first responders or first aiders, dead important. And this has been, and I'll talk to you about because I seen the surgeon yesterday. What I did immediately afterwards, I believe, has massively improved my outcomes. So I knew the injury, I knew what I'd done instantly, and I knew that this tendon had ruptured, and I knew that I needed to get my foot into a plantar flex position. So excuse this, but I've got a big boot on just now. But if you imagine, I needed my foot to be in this position. And the reason being the Achilles tendon, what you do not want is to go into what's called a dorsiflex position. So imagine that's the heel and that's the toes. You don't want this stretch on the Achilles tendon, because then you're going to then separate the fibrous, the tendon fibers further. And in some cases it can wind right up into your calf. Like let's not scare you. But yeah, I knew immediately I had to be in this plantar flex position, and that's immediately what I did. So literally seconds after I did this, I was like, this needs to be held in a plantar flex position, hold my foot down. There was no pain immediately. If I'm being honest, it wasn't sore. For me personally, it was about 10 minutes after that the pain kicked in, and it was really sore. It was sore. So they did get an ambulance. I was at a big event, so highly embarrassing, but there we are. And I got gas and air. Now, when the ambulance crew came, this wasn't something they were familiar with either. Now I had some gas and air, so I was okay by that point. And I said to them, look, you need to bandage this up in a plantar flex position, ideally 30 degrees. So 30 degrees is the kind of position that you would put it into to allow the ends of the tendons to come together and or sit close together. And so the ambulance man was very honest. He's like, right, I've never done this. So showed him how to do this. But essentially, if you're a clinician or a first responder, a first aider, and you suspect that this person has ruptured their Achilles tendon, so things that they will say, like, I just felt it go, they'll not be able to actively plantar flex their foot. Now, that on weight bearing, pushing off, don't get them trying that. So if they kind of hit the deck and go, ah, like something's pulled or whatever, even if you just assume that it's a rupture, because most people think, oh, you've just been over your ankle or you've just pulled something, and then the way that they're handled in that moment isn't great, and then possibly their outcomes down the line isn't as good. So I knew exactly what it was. I got them to basically just put support. I just needed it supported in this plantar flex position because my tibialis anterior muscles. So there's nothing wrong with your muscles that will allow you to pull your foot up like this. So I could easily do that. And at that initial point, it wouldn't really have been sore for me to do that. So imagine if you're doing that and you kind of pull your toes up, or you have somebody bandage it that way, you're actually separating the tendons. So you're possibly making that situation not a good one in the long run for that patient for their rehab. So plantar flexed and off to A&E I went. As soon as I got into A&E, I saw the consulting A&E doctor, and I'd said to him, look, I've ruptured my Achilles. He then scanned it, diagnostic ultrasound, which was actually really great because I'm going through a training for that just now as well. So we had a good look, total rupture as we expected. Now, one of the other tests they can do is a test called the Thompson test, which is where you kneel. And I got the ambulance man to do this because he wanted to practice doing it. So I said, yeah, fine, because he'd never seen it. So essentially you kneel and you just let the foot hang off the edge, and then they squeeze your calf. And what you should get at that point is a plantar flexion moment, because you're squeezing the calf, so you're contracting the calf, so the toes should point down. When you've got a total rupture, that doesn't happen, and that's basically a test. It's not a test that is, how would I put this? So it's not 100%. So a MRI or a diagnostic ultrasound would always be your go-to for your first one. So in terms of from there, what you would then do is confirm that that's the diagnosis, that's what it is, and that's what happened. And yeah, it was a full rupture. So I then said to the consultants again, he had never seen this. So that was quite interesting in that. And then, so from there, I had told them what needed to be done. So I asked them to cast me in a plantar flex position. So that I found that quite interesting. Now, it might have just been the A&E that I was in, but they weren't necessarily going to cast me. They didn't have a boot to put me in. They just said that I'd be referred to the fracture clinic, the next fracture clinic. I had a friend that works there. It's an orthopedic consultant who had informed me that, yeah, you'll just be referred to the fracture clinic, and you will be from there. You will be from there then seen and casted or booted or surgery from there. So that's what happened. That's what generally happens. The A&E, if you think about it, they're really there as that like kind of first responder, get you all right, making sure you're fine. But these kind of injuries, they're not. It's not their speciality, so it's not their thing. And that was quite apparent for me. It was a wee bit like, this is not great, because I knew what I needed them to do, so I told them what to do. But I just was thinking at the time, goodness, if there was patients here with this same injury, they might not be put into the right position that would give them the best outcomes before they get to see orthopedics at the fracture clinic. And that could be like a week away. So anyway, the front casted me in a plantar flex position as I'd requested, and that was on the Thursday, and then I was seen in orthopedics on the Tuesday. So we went into orthopedics and spoke to the consultant, and basically from there, fantastic news. Basically, the ends of the tendons were sitting close together, fantastic. And the consultant couldn't have been any happier. He just said, "Oh, that's brilliant. You don't need surgery. We will basically put you in a wedged boot and we will conservatively manage this." Now, as I was coming in to the clinic, to the fracture clinic on Tuesday, there was another lady of a similar age who had been playing basketball and had done a similar injury. And she wasn't casted. She wasn't in a cast, she just was bandaged up. And she'd done hers on the Friday. So she had been like the Friday, Saturday, Sunday, Monday, Tuesday, had just been in this bandage. So not restricting her motion fully. Now she wasn't weight bearing, but you know what it's like. You might move in the bed or you like in the shower, these kind of things. You're going to move. And she needed to have surgery. So she was scheduled for surgery. Now, whether or not her management of the rupture resulted in that surgery, that's not for me to say. But certainly just that immediate knowing, plantar flex position, do not move it, do not weight bear, is so vital. So if you're a first responder, a first aider, working in MSK, working in A&E, when we've got this tendon rupture of the Achilles tendon, it is so vital that until that patient's put into a supportive boot or a supportive cast, that they're at a 30-degree plantar flexion. Now you might be like, "Oh, I don't know what 30 degrees looks like," but essentially, even if you're like in A&E and you're casting them, even if they're just in a plantar flex position, it's actually not as steep as you would think. But if it's only going to be a few days, that's not a problem. And then at the orthopedics, when they see orthopedics, they'll put them at the right angle. But at least you're limiting that motion and you're limiting the chance of that developing. So that's definitely something that I would take away. And if you suspect that you've done this injury, just making sure that you're in that restricted motion in that plantar flex position. So, okay, so what's it been like? The first week, I have to say, the first few days were pretty grim. The pain's not too bad. It was immediately afterwards for a few hours, it was murder. It really was sore. I took codeine, the 30 grams, milligrams by 500 paracetamol. So that kind of sorted me out. They do make you a bit drowsy though. So sometimes the side effects are worse than the pain. So sometimes I quite like, so that I like pain. That sounds wrong, but it's sometimes the pain's less of an annoyance than the side effects of the drugs. I live in a townhouse. There's 3 stories in here, so that's been a bit of a nightmare because getting up and down the stairs, so you can't weight bear. Immediately what I did was I bought a few things. So the night that I did it, I bought a thing called the iWalk, and that allowed me, if you think like a pirate's leg, that's the only way I can describe it, but it gave me hands-free crutches. I'll be honest, my crutches are over there. I found the crutches, I could have cried, like when I got discharged from the A&E and they gave me crutches and I was in a cast and I had to walk. It was quite far. Hospitals are big. I thought I was going to collapse. It was horrendous. And you realise how weak your upper body strength is. So I had to like sit lots of times and my husband would get the car and it was just, see, not being able to weight bear and trying to like hop. And then I'm really worried about this hip on the left side because I don't want to damage the hip. So it was just this is a nightmare. So there's lots of different aids out there, and I will do a video and I'll review everything that I've got. So I've bought a few different things, and I've got few different boots that I'm going to talk about through this process as well. I'm going for the conservative treatment. When you look at the research out there on conservative vs surgical, over the last 23 years, the research shows that there's really no advantage to the surgery. However, there was this big debate on re-rupture rates. So, I mean, that's like, you don't want that. So surgical was always the chance of re-rupture is less than if you go the conservative route. However, if the rehabilitation is, and you boot it and you follow the protocols and you're in your 30 degrees and gradually bringing that down to your level over a period of a number of weeks. And I'm going to go through this full process with you over these videos. Then the outcomes are shown to be just as good as surgery. And then you've not got the risk of surgery and all the crap that comes with surgery. Surgery, you've got a portal of entry, you've got a wound that you're then having to deal with, you've got the scar tissue around that, you've got dressings and more appointments in hospital, no doubt. So there's a whole host of issues with, surgery that I did not want to. Surgery should always be, in my opinion, certainly something with my patients, it's on the table, but it should be the last thing that you look at. It should be like, yeah, do you know what? I have no choice, or that's going to give me that better outcome. It's definitely better for me, but it shouldn't be like your first choice. Let's go for surgery. It should always be, let's review everything else. Let's look at the evidence that we've got, and let's see. Sometimes, certainly the rehab of this will be extensive. And I remember when I was doing it, I was sitting on the grass just like a few minutes after I'd done it, and all I thought was, God damn it, I'm going to be in a boot for 12 weeks. That's literally where my head went, and I actually felt the gap, and I'm like, all right, it's not too bad. So I was literally assessing how bad it was before the pain hit, that was. And yeah, this is a slow process. There's nothing I can really do to heal that, speed this up. I've got to just let my body do what it does and trust that it will heal. It will heal. But I've got to do my part. So the mobility side of things, look, I'm not going to lie, it's pretty grim initially. Use the help. Taking a shower is, you need a seat in your shower. There's just no way. Taking a shower feels horrible. It's, yeah, just grim. You will want to get, you get these limbo. So I had one anyway, because when I'm doing surgery on somebody's leg, we always give them a thing to put over so that the dressings don't get wet. So there's these things called, it's like limbo limb, it's called. If you just Google it, you can get them off Amazon, you can get them anywhere. They're about 20 quid. And you just reuse it. And essentially it's like a big plastic thing that goes over your leg and stop, so you can have a shower, no problem. But then when you're in a boot, you're grand. You can take your boot off to shower, but I'll talk through that in the next video. But essentially, your first few days after this, you cannot weight bear on it. And to be honest with you, the first 2 to 3 weeks, total non-weight bearing, certainly not without being in a boot. Everybody's circumstances will be slightly different, but you don't want to weight bear this. You'll be using your crutches even while you're on the boot. The eye walk, something I bought, did really help for those initial few days. Now, not so much, because I'm partial weight bearing with the boot, with my crutches. I have a knee scooter for work. I've got, my work's quite big, so although I can stand up and use my crutches and walk, I want to minimise the motion and movement on this right now in these initial few weeks. So having a knee scooter will assist me with that. So I've just knew these kind of things. So for you, you need to look at your house, look at how you're going to manage stairs, whether most people will maybe just shuffle down in their bum or crawl up. You need to think about your knees if you're going to do that. So I bought some knee pads, because in the early days of this injury, when you're getting up in the morning, I just put my knee pads on and crawled to the toilet. I know it's so glamorous, but that was the easiest way to do it. So you just need to think about your other joints and things as well, and don't end up with secondary injuries because of this initial injury. So I bought some knee pads off Amazon. I think they were like a tenner. Just nice soft knee pads to just help me get about in those initial 5 days, and that did help. Your upper body takes a bit of a pounding, so you need to make sure your neck and your overall posture is good there. I would definitely recommend getting a pillow for supporting the leg, having it up. It does help with healing and blood. Your body doesn't have to work as hard. Um, and comfort as well. And maybe if you're able to lie on your side, which I am able to do, a pillow between your legs and things as well will just help with that overall sleeping posture. Um, in terms of me, I am 44, and obviously I'm going to be pretty much immobile in this leg. So the risk of that as well, you've got a risk of DVT, deep vein thrombosis. So your doctor will no doubt start you on blood thinners. That's something you'll discuss, but just make sure that that has been discussed. That's a serious discussion that you need to be having. So make sure that that conversation is had with your healthcare professional. It will usually be in the A&E you would have that. So if they're not giving you blood thinners, certainly ask that question. Your health status will be different to mine, but certainly that's a conversation that needs to be had. So I am on blood thinners, and I'll no doubt be on these for the next few months. Fine, it's a small price for my bruised ego with running. So that's it for now. I wanted to just give this initial kind of overview. Um, these injuries are common. Your Achilles tendon rupture is the most common tendon to rupture, and it's usually men, and it's usually weekend warriors. As people, like what I've done, just really stupid. Women do get it as well, but I think the ratio is like 10 to 1. So for every 10 men that get it, 1 woman gets it. So it does tend to be men more so than women. Tends to be people in their 30s and 40s. I'm right in that. So that is an Achilles tendon rupture. So here I am. So I'll do one of these weekly. On the next one, I'll talk about the boot. There's a couple of different types of boots, and wedging and conservative treatment via surgical treatment. And we'll talk about what I've started doing in my rehab and things as well. So because there's things that I'm even doing at this stage with my rehabilitation, and that will continue on through the week. So I hope this has been informative, and please follow, please like, please subscribe, please share this with anybody that you think that would get use out of it. And please comment, please let me know how you're getting on in your recovery, or if you're a clinician and you've any questions on this, please feel free to hit me up. I'm pretty well versed in this, and I fear at the end of this I'll be pretty much an expert at Achilles tendon injuries. See you later.